I've actually been in the practice of medicine for 40 years. It's hard to believe. And, yes, I feel fabulous and I'm still at it. And, but, I started when I was about age 2. So as I say, we do the math. I wanted to thank, first of all, the Florida Asthma Coalition for welcoming me into the family. I don't have the honor of seeing Dr. Wanda here today, but the entire team, including Dr. John Zan, who we've seen somewhere in the virtual world, Tiffany, Caitlin, Shelby, Emily, Teresa. If I'm missing somebody, please, forgive me. But this is a fabulous, fabulous initiative. Please get involved, join, and do something for your community as part of our coalition. So without further ado, I'm going to discuss with you today's objectives are to recognize that asthma is a heterogeneous syndrome encompassing clinical phenotypes that differ according to the age of presentation, whether lung function is preserved or compromised, whether allergy is present or not, and whether the patient is responsive to corticosteroids. It's important also to recognize that asthma in older adults is frequently underdiagnosed, misdiagnosed, and undertreated. And to appreciate asthma in the older adult is associated with greater morbidity and higher mortality rates compared to younger cohorts. To understand that medical comorbidities are common in the older adult and may mimic symptoms of asthma. And to understand that older adults are more vulnerable to polypharmacy and at risk for adverse events. And to review current asthma guidelines and emerging strategies to address both symptoms and the underlying shifting patterns of inflammation across the lifespan. The National Institute of Health and its National Institute on Aging generally describes the older patients, adults age 65 and older. However, the definition of older adulthood varies. Behold, the new old. Age 77. Willie Nelson, age 90, still on the road, honey. And our beloved What's Love Got to Do with It, Tina Turner, whose lecture I was thinking about the title, age 83, passed last year. And Mick, the Quick Jagger, age 80, still on the road. If this is old, I'm signing up. But as John referenced, this is ancient. And the story of asthma and the Iliad go way back about 2,700 years ago. The word Asian first appeared about 2,700 years ago in Homer's Iliad, which is an epic poem recounting the 10-year Trojan War while exploring themes of pride, honor, and the human condition. And the word means to breathe hard with one's mouth open in a panting way. And here depicted in the triumph of Achilles, you see the warrior Hector captured and dragged by Achilles to the gates of Troy, and described in the Iliad. He saw Hector lying on the plain, his companions sitting around him, and Hector was gagging painfully, referring to asthma, dazed and vomiting blood. And this is the early description of hematemesis from the Greek word ama. Asthma is the most prevalent chronic respiratory disease in both children and adults, and it's a complex syndrome rather than a single disease with varying manifestations at different stages of life. And risk factors include genetics, family history of atopy and asthma, respiratory tract infections early in life, allergic diseases, and less than optimal lung function. And I think you've heard my two colleagues give some of the most fantastic talks that I've ever been privileged to listen to, enumerate on a number of these points. While a new onset of asthma symptoms is apparent for some in adulthood, many do not recall symptoms during childhood, or alternatively, we're told that they had recurring bronchitis. Adult onset asthma may reflect a relapse of disease after a prolonged period of quiescence, rather than a spontaneous de novo event. Moreover, although signs and symptoms are similar to younger patients, the diagnosis can be challenging due to the presence of coexisting diseases. We have now a discussion of the march, as we say, as time marches on. This is an illustration of the chronology of our biology, otherwise known as the atopic march. And note the distinct and rather orderly disease expression to include the start of atopic dermatitis in infancy with the onset of xerosis or dry skin, followed by the development of food allergy, then nasal allergy symptoms or rhinitis in the early preschool years, and then finally asthma, which for some, as Dr. Perpich mentioned, may start within the first year of life. And while there's little that we can do about our chronology, we've learned lots about the biology and underlying mechanisms in each and every one of these disease states. And with this expanded understanding, so have the myriad of therapeutic options used to address each of the disease states mentioned, especially asthma. Worldwide estimates support doubling the number of older adults aged 65 and older by 2030. And in the United States by 2050, this age group will account for 25% of the population, or 40 million people. And asthma prevalence in the older adult is challenging to determine due to underdiagnosis, perhaps due to underreporting of asthma symptoms, attributing symptoms to comorbid disease states, or misdiagnosed COPD. Overall, there appears to be a lifetime prevalence in older patients of approximately 13%. We basically have to get ready for this new reality and become lots better at what we're doing. Now, some populations are at higher risk for dying from asthma than others, and this slide depicts asthma mortality by select sociodemographic characteristics in 2021. Older adults, females in particular, male children, and not illustrated here, Black Americans have a higher rate of asthma deaths, especially Black females. As it relates to the older adult, asthma is more likely to be underdiagnosed, as I mentioned, and undertreated. And throughout this talk, I will highlight contributing factors and the challenges they present. While important at any age, the appropriate diagnosis of asthma in the older adult is critical and challenging, as many patients will present with comorbid mimics of asthma. And this is important to keep in mind to avoid inappropriate interventions or overtreatment without considering other important diagnoses. Following national and asthma global guidelines obviously apply, and there's nothing like a detailed history to include the description of symptoms, timing of presentation, giving emphasis on a past history of childhood asthma and allergic rhinitis, triggers, what sets them off, and what gets them better. But remember, shortness of breath or dyspnea is a common symptom of other chronic disorders, and older adults may be poor perceivers of dyspnea, even in the presence of significant airflow limitation. There is a common perception among some clinicians and patients that allergic diseases are not relevant in the adult world. And this is illustrated by a previous and widely held belief that asthma in the older adult was somehow intrinsic or non-allergic. And although measures of allergic sensitization, such as a skin prick test, specific or total IgE declines with age, the association between allergic sensitization and allergic disease, particularly asthma and allergic rhinitis, remains robust in the allergic population. The rate of allergic sensitization is higher in older adults with asthma versus age-matched controls without asthma. How sensitization translates into disease severity is not clear. Consequently, an appropriate evaluation of allergic sensitization is still warranted in older patients to provide comprehensive and optimal care. The baggage. While traveling the road of life, It's not uncommon to pick up 1, 2, 3, or more comorbidities, medical conditions, or the baggage. And this is especially important in the older adult with asthma. As many of these conditions present with symptoms similar to asthma, this is not a complete list. Let's take heart disease and acute left ventricular failure and associated pulmonary edema and wheeze. I've seen patients present for the first time with so-called asthma and florid congestive heart failure. You have obesity with restriction of the chest wall and deconditioning due to reduced mobility, patients complaining of dyspnea. With cognitive decline, this individual may have a reduced perception of dyspnea in addition to difficulty with self-administration of medications, their inhalers, or nebulizers. So-called known COPD, is it really COPD? Has this been misdiagnosed? Has this patient presented with symptoms triggered by known allergens, changes in weather, et cetera? What happened to the history? What does their history indicate? For example, if the timing of the onset of symptoms occurred earlier in life, maybe they've had asthma in childhood and they went through a period of quiescence and now it's returned rather than this de novo event. And of course, we're all aware that gastroesophageal reflux can present with cough. Now, here's some of the good news. The changes that occur, the inevitable changes with walking that road of life. And with chronologic advancement, certain structural changes are to be expected in the lung and chest wall. And these changes have effects on the mechanics of lung function. And again, again, starting with the lung, there is this deterioration in the collagen fiber network that coils around the alveolar duct, and this leads to dilatation of the duct and alveolar enlargement. Now, in contrast to emphysema, there's no destruction of the alveolar wall. This alveolar enlargement leads to decreased alveolar surface tension and a reduction in the elastic recoil, thereby creating a stiffer lung. Now, there are changes in the chest wall with aging. There's an gradual increase in rib calcification, leading to a more rigid chest wall. And you also have age-related curvature of the thoracic spine associated with desiccation of the intervertebral discs, which allows for compression under the weight of the patient's body and formation of this characteristic kyphosis deformity. The curvature appears more pronounced in females with osteoporosis. And overall, you can appreciate a progressive loss of volume and a greater restriction of the lung cage. With muscle strength, there's a gradual age-related reduction in muscle strength, respiratory muscle strength that's due to related atrophy of the diaphragm and intercostal muscles. And together, these changes and the effects due to asthma can create a more difficult to manage scenario. With aging comes expected changes in the mechanics of lung function, and some highlights include a decrease in expiratory flow, the FEV1, associated with reduction in static recoil pressure, and consider the normal 30 milliliter decline in FEV1 and FVC by age 30. Ha ha. So some of you are sitting there. Take a deep breath. It's already happening, honey. And this is in a non-smoker. And important to consider that this is a normal accelerated decline in FEV1 and FVC between the ages of 65 to 93. The FEV1 FVC ratio also declines, producing what looks like an obstructive pattern. And that's why it's essential to use age adjustment values when evaluating spirometry in an older adult. I love this one, senescence, immunosenescence. So with aging, there are alterations in both our hardwired, innate, and adaptive responses referred to as immunosenescence. And certain pro-inflammatory cytokines, such as interleukin-6, IL-1 beta, and tumor necrosis alpha, tumor necrosis factor alpha, normally increase in a process referred to as inflammaging. The eosinophils may have decreased effector function as time marches on, and neutrophils appear to take up residence in the airway even without asthma. and they appear to increase in the sputum of the older patient with asthma. So consequently, we're to expect greater levels of these toxic neutrophil mediators, changes that are seen in a subset of patients with severe asthma that are poorly responsive to corticosteroids. Regulatory T cells or Tregs are thought to suppress airway inflammation and airway hyperreactivity, and these also appear to be reduced in the older patient with asthma. The language of airway inflammation involves a robust conversation of redundancy, amplification, and feedback amongst innate and adaptive immunocytes like dendritic cells, T helper cells, innate type 2 lymphocytes, B cells, eosinophils, mast cells, and structural cells like the epithelium, smooth muscle cells, goblet cells, fibroblasts. And it's this conversation that's propagated by the production of pro-inflammatory cytokines and chemokines made by these same cells. It's the upregulated expression of these proteins, especially interleukin 4, 5, 13, thymic stromal lymphopoietin, interleukin 25 and 33, that produces the downstream effects of mucus production, smooth muscle hyperplasia and hypertrophy, thickening of the basement membrane, narrowing of the airway, airflow limitation, and an exaggerated response to a variety of triggers. Several of these cells and their protein messengers are direct targets and indirect targets of the monoclonal antibodies that both my predecessors just mentioned, often used in the young and older individual with moderate to severe asthma. The asthmas, as you heard today, there's more than one. And asthma is a heterogeneous syndrome encompassing several clinical phenotypes, reflecting the observable clinical and physiologic characteristics of that individual. Investigators have characterized these phenotypes according to the age of onset, whether young or late, whether lung function is preserved or not, and whether allergy is present or not. And using another approach referred to as cluster analysis, 4 consistent clusters have been identified. An early onset allergic asthma patient who has preserved lung function, a young child with allergic asthma with evidence already of airway remodeling, and these may be in some of the preemies or some of these early respiratory infections that we mentioned. Later onset non-allergic eosinophilic asthma with preserved lung function, and onset non-allergic, non-eosinophilic type 2 asthma with this neutrophilic asthma with low lung function. And this group in particular is challenging because they're less steroid responsive. And on the right side of the slide, and remember too, I just mentioned that in the older adult with asthma, and what happens naturally is that you're expecting an increased infiltration by neutrophils. So this may make their management even more potentially difficult. On the right side of the slide, and again, this is kind of difficult to read, a deeper dive into the specific biology of the phenotypes is characterized by the predominant white blood cell or granulocyte that drives the disease. At the bottom of the first column, identified in the severe asthma research program known as SARP, you see a later onset eosinophilic non-allergic group, a later onset non-allergic neutrophilic group with severe asthma and fixed airflow obstruction. And then you see in column 3, another investigator identified a group with near fatal asthma with high eosinophil counts and a low pre-bronchodilator FEV1. And lastly, you have Simpson and others doing manual sputum examinations and identifying a predominant eosinophilic group, a neutrophilic group, a mixed group, and this is the overlap that we have to keep in mind, that sputum that has high eosinophils and high neutrophils, and the one with paucigranulocytic sputum that has little cellular infiltration by eosinophils and neutrophils. And keeping these concepts in mind, the biologic pathways that underlie asthma can be broadly divided into a paradigm or model of 2 endotypes, T2 high as defined by at least one of the following: sputum eosinophils of greater than 2%, an absolute eosinophil count of more than 150, exhaled nitric oxide of greater than 20 parts per billion, and asthma that is clinically driven by an allergen or that has demonstrable and also with demonstrable specific or total elevated IgE, and asthma that requires bursts of systemic steroids. So the ones on the top, the sputum eosinophil counts, which are not commonly done, but absolute eosinophil counts reflecting the airway, FeNO, total IgE, those are the biomarkers that are often spoke about in our discussions. And within the T2 high asthma bucket, you see allergic eosinophilic asthma and aspirin exacerbated respiratory disease, which is an eosinophilic driven disease, and their related cytokines, comorbidities to include atopic dermatitis, food allergy, chronic rhinosinusitis with nasal polyps, and even reflux for some. And note the later presentation of some of these to include eosinophilic asthma and aspirin exacerbated respiratory disease, as I mentioned. And then you have this entire other bucket, the type 2, the T2 low, that presents later in life, characterized by neutrophilic infiltration driven by Th1 and Th17 cells, or the paucigranulocytic, where few inflammatory cells are present. And it's important to keep in mind that this overlap exists for many individuals, especially for those with T2 high asthma, as they can be both allergic and eosinophilic. And moreover, things can change as part of a continuum. Again, I've been in practice for a very long time, and I have adults who developed allergic asthma in childhood, who as adults grew up to have steroid-dependent asthma, aspirin allergy, chronic rhinosinusitis with nasal polyps, and a vasculitis. So we talk about this epigenetic story and this unfolding of genes, and this is certainly happening before our eyes. My greatest teachers are my patients, and Nicole has taught me, has humbled me in my practice, but has taught me so very much. We talk about the asthma triggers, and the allergic individual with asthma is sensitized to and responds to airborne allergens like dust mites, pollen, and animal dander, presenting with ocular and nasal allergy symptoms, sneezing, itch, rhinorrhea, cough, and chest tightness. And many of these same individuals are also triggered by irritants like smoke, strong odors, irritants, and changes in weather. And then, as you can see, there are numerous respiratory microbes that can affect the upper and lower airway and trigger symptoms and a potential exacerbation. And lastly, you see how easily these microbes are transmitted. Current evidence-based guidelines for asthma are derived from studies on younger individuals, as older patients are frequently excluded from clinical trials. Asthma is often undertreated in older patients, and factors include decreased self-management with aging, misdiagnosis, poor access to appropriate specialty healthcare, cost of medications, fear of steroids, and poor drug delivery. And fear of steroids, yes, even to include, has been mentioned, even for the moms, younger children, adults fear the inhaled corticosteroids. Regardless of age, the guidelines advocate for a continuum of assessment, adjustment, and review of the patient's clinical course. And remember, this is a partnership. And as such, we need to understand the patient's perception or lack thereof of their given situation, their level of satisfaction, and maybe they shouldn't be satisfied with the status quo, their preferences, their goals. The comorbidities are mentioned throughout every aspect of this continuum, especially as it pertains to the older adult. Comorbid conditions are certain to be part of the mix. And after thoughtfully reviewing their history, exam, and objective measures of lung function, targeted recommendations are made. And it's critical to let your patients in on what you're thinking. What's your rationale for deciding one option over another? And be prepared to change or adjust upward or downward. Along every step of the way, it's education, 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 and skills training remains the top priority for every office encounter. And many of you are familiar with the STEP guideline approach to asthma management, and whether national or global. More recently, there's been a paradigm shift or a change in our approach to rescue therapy, starting with step one. An anti-inflammatory rescue approach, the AIR, understanding that inflammation is the reason for your patient's asthma season. It's inflammation that drives cough. It's inflammation that drives shortness of breath. It's inflammation that drives that tightness of the chest and wheeze. The NAEPP 2020 Focus Guideline Update and the most recent GINA guidelines, which just came out, support the concomitant use of a systemic steroid, an inhaled corticosteroid rather, when using a short-acting bronchodilator for rescue. We call this the anti-inflammatory rescue, or AIR. SABA alone is no longer recommended by the guidelines to address asthma symptoms due to increased morbidity and mortality. SABA alone does not address inflammation. ICS formoterol as a single maintenance and rescue therapy is a great idea, but it's not FDA approved to be used in this manner. More recently, an FDA approved anti-inflammatory rescue albuterol budesonide, and you have a booth outside, this combination, this inhaler, as a rescue reliever while reducing the risk of exacerbation has made its debut. One of the main goals of all asthma plans is to reduce symptoms while minimizing exposure of the patient to systemic corticosteroids. And when addressing inflammation and symptoms together, there is a reduced risk for a full-fledged exacerbation and initiation of systemic steroids. And why is this important? Well, glucocorticoids are commonly prescribed in the management of inflammatory and immunologically mediated conditions, rheumatologic and autoimmune diseases, inflammatory bowel disease, allergic reactions, and of course, asthma. And don't get me wrong, any one of us who's in the business of patient care and asthma management, regardless of age, has used and will continue to use systemic corticosteroids. And they can be life-saving during an asthma exacerbation that's particularly severe. But it's the risks associated with repetitive courses to control asthma that's the problem. Even short courses of steroids, systemic steroids, have been associated with increased rates of sepsis, thromboembolism, and fracture within 30 days of an OCS type initiation. Acute and longer-term systemic corticosteroid use are associated with a lifetime cumulative exposure and systemic corticosteroid-related adverse effects. And the onset of some of these adverse effects is noted with only 500 milligrams to less than 1,000 milligrams, which again is significant for those who can develop type 2 diabetes, anxiety, and depression. And this is equivalent to about 4 lifetime courses of systemic corticosteroids to treat an asthma exacerbation. So even short courses of steroids are a big issue. And the key, again, is optimize your asthma therapy to minimize the need for systemic steroids. The study on the right by Price, Trudeau, and others illustrates the positive dose response curve, well, actually the positive dose response and multiple adverse outcomes associated with cumulative exposures to systemic corticosteroids. And just look at this list: type 2 diabetes, renal impairment, hypertension, cataracts, just to name a few. But what's not listed here is adrenal insufficiency. And I measure morning cortisol levels in all patients who have been on repetitive courses of steroids, and especially those who may be prescribed a biologic. This information is necessary, especially when you start tapering patients on long-term steroids. Let's do the math. Did you know that a typical course of systemic steroids to address an exacerbation, what I use is prednisone 20 milligrams twice a day for 5 days, which is equivalent to 200 milligrams or 200,000 micrograms. The recommended dose for that little purple discus, fluticasone, propionate, salmeterol, 100/50, is 1 inhalation twice a day. or 200 micrograms a day. It would take 1,000 days or 2.74 years of this inhaler taken at 200 micrograms a day. Here's the math, 1,000 times 200, 200,000, 200 milligrams to reach a numeric equivalence of a 5-day course of prednisone. 5 days of steroids, and patients are afraid of inhaled corticosteroids. Now, I'm talking numeric, but there is a translation to the physiologic effects. So this is a dramatic understanding. Again, we need to remind ourselves and patients why maintenance corticosteroid therapy is far more preferable. Here are the FDA-approved targeted biologics. And in the past, as you've heard mentioned, asthma was treated as a one-size-fits-all approach where patients received the same medication regardless of their specific characteristics, and with treatment primarily addressing symptoms without targeting the underlying inflammatory processes. However, the introduction of biomarkers has advanced the concept of precision medicine, which now takes into account the individual phenotype and endotype of each patient. And one of the greatest contributions to personalized asthma care came from the development of these monoclonal antibodies, which are used to treat more severe forms of the disease, especially those with type 2 high inflammation. And depicted here are the currently available biologics approved for use in asthma and their targets. And you see that more recently, we've had an approval for benralizumab for age 6 and above, and we see dupilumab, age 6 and above, mepolizumab, age 6 and above, I have to, here, omalizumab, age 6 and above, Rezi, age 18, and tezepelumab, age 12 and above. And take a look where in the cascade it blocks these signals within the inflammatory cascade. And just for a little bit of a deeper dive, omalizumab targets IgE, preventing its binding to mast cells. There are 2 biologics, mepolizumab and mezlizumab, that target interleukin-5, which is a key cytokine involved with eosinophil development, migration, survival, and activation. And then there's benralizumab, which targets the IL-5 receptor alpha subunit on the surface of the eosinophil, and through a unique mechanism of action referred to as antibody-dependent cell-mediated cytotoxicity, causes an implosion and depletion of eosinophils by natural killer cells, as you can see on the right. I mean, the science is so neat. I love that. I call that the kiss of death. And next you see dupilumab, which targets the interleukin-4 receptor alpha subunit common to type 1 and type 2 receptors found on immunocytes and structural cells, thus curtailing these downstream effects. And lastly, you have tezepelumab, which targets thymic stromal lymphopoietin, TSLP, which is an epithelial-derived cytokine at the top of the inflammatory cascade that's critical to the downstream propagation of inflammation throughout the airway. And so by targeting these key cytokines and cellular targets, the intracellular pro-inflammatory signaling is blocked. Older patients may be more sensitive to adverse effects of beta-2 agonists, particularly those with unstable cardiovascular diseases. And the potential risks of inhaled anticholinergics, which some of us use again in triple therapy, include dry mouth, symptomatic urinary obstruction, closed angle glaucoma. Needless to say, comorbid disease states may modify pharmacokinetics and the pharmacodynamics of these medications. And this has to be taken, of course, into account when we're treating patients with asthma. Renal impairment, hepatic diseases can affect and impair absorption, distribution, and metabolism and clearance of these drugs while increasing the potential for side effects. And consider the drug-drug interaction of polypharmacy used to manage many of these conditions while managing asthma. And herein lies one of the most important roles of our pharmacy team members in terms of supplying us as the practitioners with drug compatibility profiles, which again, I urge all of us to consider when we're prescribing these medications, especially in individuals who are on numerous medications. And managing asthma in an older individual with one or more multiple comorbidities requires a lot of awareness, skill, and a lot of balancing. And medications always hold the potential for adverse effects. And as it pertains to asthma, commonly prescribed therapeutics to address asthma itself or a commonly or comorbidity deserve special attention. And as you see here, non-selective beta blockers and bronchospasm, even eye drops have led to fatal attacks for some individuals. We have the tachycardia, tremors in patients with underlying cardiovascular disease that may be particularly sensitive. The use of aspirin and non-steroidal anti-inflammatory drugs in patients with aspirin-exacerbated respiratory disease. And you may find some of your first asthma exacerbations may be in individuals who have developed that new onset of aspirin allergy. And then you have the ACE inhibitor, the angiotensin converting enzyme inhibitor, dry cough, angioedema in individuals with hypertension on this particular antihypertensive drug. So for all clinicians and providers at every level, ideally there should be a multidimensional approach to delivering the goods. And just like Mr. Postman, circa 1930, who uses a front and back approach as a team to include clinicians, pharmacists, respiratory therapists, nurses, and social services, namely many of you, we can help to identify the most vulnerable amongst us and to ensure all aspects of care are executed according to plan recommendations. And this is why groups like the Florida Asthma Coalition are so important. It starts with education of ourselves and those we serve. The see one, do one, teach one approach that I learned in residency, that I impart to colleagues and my patients, residents. See it, do it, teach it. That's how you learn. Careful monitoring of inhaler technique. You know, we prescribe medications, presuming that patients are going to get that inhaler. Maybe they got switched at the pharmacy to a discus, and they have to understand the differences of these devices and understanding the need of also for the right rescue and controller therapy, understanding their cognitive abilities, decreased muscle strength, arthritis. This affects manual dexterity and limitations on how patients handle these devices effectively. DPIs, dry powder inhalers, require higher inspiratory flow rates, which may be difficult for some older adults to generate, and consider other delivery systems to include adult spacers with a mask and nebulizers. Don't forget, some people don't hear well, they don't see well. And again, depression can put a big veil over what you're hearing and what you're seeing. And you need to take your time with these individuals. Pharmacy benefit managers, insurance formularies, their preferred lists may differ from that which is prescribed. So we always have to ask, did you get the prescribed inhaler? And if they say no, you really have to take a deep dive into what happened. And this is why the coalition, and if we can partner with identifying these patients, that we can kind of go over these boundaries and through these loops and hoops, and hopefully get patients targeted to the right medication and exactly what was prescribed. This team approach, again, is essential to ensure all aspects of care are executed accordingly. So these last words, again, Joan Collins, age is just a number. It's totally irrelevant, of course, unless you happen to be a bottle of wine. George Burns, you can't help getting older, but you don't have to get old. And anyone who stops learning is old. And whether you're 20 or 80 or anyone who keeps learning stays young. And that's really why we're all here today. And of course, my quintessential New Yorker, Yogi Berra, it ain't over, honey, till it's over. Thank you again for your kind attention. Thank you.
Dr. Ramirez, we actually had one question real quick online while the other questions are coming in. One of the virtual participants had a question about the asthma phenotypes. And when you said age of onset, early versus late, the question was, does age of onset, is that greater than 30 or greater than 65 years old?
Which, the age of onset. Let me go back to that slide. So we're talking in terms of the phenotype. Here we are. So the age of onset, we're talking early versus late, childhood versus older, in the adults. So it's kind of a blurred line here. So no absolutes. But the early onset allergic individual, we're talking a child generally with preserved lung function, and some of these kids already come into this with airflow limitation. But looking at more on the adult side, presenting again more of this late onset. So we're talking more of a de novo presentation. They're the older patients. So again, older patient, I would consider, 20s, 30s, 40s, 50s, and beyond.
Yes, I just wondered what your thoughts were on the correlation between COVID-19 infection and then being diagnosed with asthma shortly after,
Okay.
but never having
Okay,
diagnosis.
that was very, as we mentioned, thank you again for that provocative question. Well, we think that theoretically it may have been that the infection itself woke up these innate type 2 lymphocytes that are involved with the production of interleukin-5 and this eosinophilic trafficking. And we think that that may have been the problem. I mean, COVID was enormously destructive, but, interestingly, it was patients with poorly controlled asthma up to that point were at risk. Having asthma itself wasn't a risk factor for having worse COVID. So you hope that you were under good control. And indeed, most people were staying home, not becoming exposed to airborne allergens or other microbial infections. But we think it has to do with the innate immune system having been challenged with this newly recognized virus and awakening our immune system and the production of interleukin-5 and eosinophilic asthma. It's fun to get older.
Are there any additional questions in the room or online?
Thank you, Dr. Ramirez, for bringing up how structural changes affect some of our more senior patients.
Yes.
How are you guys working with, or do you guys at least have recommendations for working with either physical therapists or respiratory therapists for accommodation for those structural changes?
I got to tell you, we're woefully deficient. I think that it's the coalition that, working together, we can promote the change that we want. And I think it's very important to identify those patients. So in the busy single specialty practice of allergy immunology, where I see children and adults of all children of all ages, I know for a fact that, and it's a large group, and most allergy groups and most pulmonology groups, I would dare say, are not working with our ancillary brothers and sisters in that regard. And when you see these changes in individuals, and we take too much for granted. And I think that you propose a very interesting thought, and perhaps you may be part of starting an initiative to have respiratory therapists again identifying patients at risk. And certainly, I think that it's not only the structural changes, but identifying the cognitive abilities of individuals and the changes that occur, and that we prescribe things quickly and say, well, our job is done. Our job is not done. our job is really never done in that regard. And so if we don't identify the gaps, and patients do fall through the gaps, then we're going to continue to see this unfortunate morbidity and mortality associated with our population, who, as I mentioned in the opening slide, is only getting older. And so we have to do a better job, because we're coming your way. Yes.
Therapists that work in the hospital, other than to identify these patients, especially the older patients that come in, that usually get diagnosed COPD, no history of an exacerbation. I'm treating them like a COPD exacerbation, but yeah, they smoke. But how do you identify other than an elevated eosinophil count? Like, is there any other?
Well,
markers
I
that
think,
need
well,
to look for?
again, the history, lung function, if it's fixed airway obstruction, is there emphysema? Is there, again, has there been an opportunity to look at plethysmography? Do you have this, this significant air trapping? So, is this an overlap syndrome? Is there a degree of reversibility? But just because a patient's older doesn't mean that they automatically have COPD, and that's the problem. And then they're mistreated, they're underdiagnosed and mistreated. And there is a degree of this, being dismissive to an older adult, and it's called medical gaslighting. And so I think that, we have to be aware and sensitive to patients that just because you reach a certain age doesn't mean you fall off a cliff. And we have to also include in that our earnest efforts to include accessibility to these medications that for some reason at the golden age of 65, when you hit Medicare, you can't get it anymore, but still your disease process follows you. And so it's going to cost a lot more to the system to have you in the hospital with an exacerbation, and it costs a life. And people are getting older, as I say, look at Cher, look at Mick Jagger. I mean, this is a new way to think about things. And I think as a society and as a group, there's a lot we can do together to kind of turn the tide in that regard. But thank you for asking that, because I just think that it's often a misdiagnosis because of what we've been used to looking at people, again, according to this ageist bias.
Any other questions? Any other questions?
Virtual question.
So there's a question that came in online. It says, when a medication or treatment is no longer effective for a pediatric patient, is it due to, bear with me, tachyphylaxis and tolerance, or is it due to airway remodeling and cellular changes?
Well, let's make sure that we're giving have the right diagnosis, the right reason for that season. Because again, it starts with diagnosis, history, diagnosis, and then you have your targeted approach. Maybe things are not working if it's not the right thing from the get-go. And maybe things are not working because it's the incorrect approach, the incorrect medication. And yes, changes can occur, and there can be progressive airway remodeling or dysfunction. But again, if you're controlling, if you're recognizing and controlling inflammation, it shouldn't, hopefully by these gatherings and understanding guidelines, you should have an increased awareness of your options that exist in a stepwise progression. Tachyphylaxis per se shouldn't be an issue, as should be overuse of a SABA without recognizing that inflammation is driving the symptoms. And this is where this paradigm shift has turned around. In the early 90s, one of my colleagues who, as an adult pulmonary fellow, did biopsies in adults that were not symptomatic. Bronchial biopsies in patients without asthma. And then she also did patients who had very, very mild asthma, no symptoms. And in the mild asthma group, there were already changes of inflammation. So there was thickening of the basement membrane. There was already disruption of the epithelial lining and infiltration by neutrophils and eosinophils. So even in that patient with asthma who's not having symptoms, inflammation is present. The symptoms, which again has been our focus with the guidelines, starting with step 1, and it's still in the national guidelines. GINA does not approach step 1 therapy with SABA alone. And although the national guidelines recommend the use of ICS and SABA together, we still see recommendations for SABA alone. You have you cough and wheeze. Now you can use a SABA alone approach in an individual who you feel confident that's already using an inhaled corticosteroid. And I don't know about you all, but my patients, once they start feeling better, a lot of them stop taking medication. So adherence is a big problem. They stop taking their medication, and then because they feel better, they're in denial, we're in denial, and then things begin to happen. So to have that exacerbation, it has to be more than just albuterol. And this, I think, represents one of the greatest shifts in the paradigm of step 1 to understand this anti-inflammatory rescue approach. So getting back to that individual's question with regard to tachyphylaxis, it's more, I would believe, the point is more of the inappropriate use of a medication that should no longer be part of our daily armamentarium in addressing step 1 therapy. It should be ICS and a bronchodilator together. The ICS formoterol approach is outstanding, but we do not have an FDA product that can be used in that manner. We have products that are there, but if we have patients directed to use their ICS formoterol, which is a long-acting bronchodilator, which acts quickly, if using it more than just twice a day, they may run out of their inhaler by the end of the month. And then we wind up having patients who fall into a gap, who have no medications to cover those last several days, and then wind up with an exacerbation. And I just saw this in my office, a woman who I changed controllers, and the pharmacy gave her a bronchodilator inhaler. And she came into the office within a 3-week period for testing, and she was having an exacerbation. And I'm saying, what's going on? Because I changed her to an excellent dual controller. And I said, could you look up what you got? And what she got on her phone was albuterol. So she didn't get what she, so again, you got to ask the questions. And it's not a day that goes by. Pharmacy benefit managers work together with insurance companies, and it's not always to the benefit of our patients, because it makes it less accessible for some of these medications that they've done very, very well on, but then are no longer, it's so too bad, you know, you don't have it anymore. No, we have to become more, we have to become the advocates that they ask of us to become. Everything within reason, of course, but not all inhalers are the same, as not all patients are the same.
And we'll take one final question, and it's online. How do you prescribe SABA/ICS if using as a controller and a rescue medication for insurance purposes?
Well, that's what I just mentioned. You can't because you can't, because it's not an FDA approved. It makes it easy. It's not approved by the FDA. Once it does, then we talk about it. But in terms of the ICS SABA product that is here today as one of the sponsors of the conference, I tell patients to use it as they use albuterol every 4 to 6 hours. And I would urge you to go by the booths and visit all of our exhibitors because they support this conference. But stop by if you're interested in any of these new step therapies. Please, I'm sure the group will be very happy to share with you this information. Thank you again for your attention. Thank you.